ancestral spirits, forming a psychotherapeutic assembly, and this can foster kin and community cohesion. Third is the culture congeniality and holistic approach, which integrate cultural value systems of the patient and the physical, psychological, social, and spiritual aspects of healing. Fourth is the personality of the healer himself, who, in order to be successful, has to be able to achieve and maintain a certain confidence-inspiring charisma. Indigenous healers, we know, undergo a mind and life-altering experience and process before they become a healer. Our experience is only the medical school and psychiatric training, and I think it pales in comparison with the so-called psychotic states of the would-be healer. Fifth is ceremonial format of healing composed of several ritual elements which involve not only the patient but also his in-group from whom he may have become alienated. Lastly, social engineering by giving advice with authority and by direct or indirect manipulation of the client's immediate human environment. Indigenous healers specializing in mental health care often temporarily accommodate the patient in their own home or in a compound or in a healing shrine adjacent to their home while the patient maintains close contact with his family and he is immersed in a daily ritual activity and household occupations which constitute effective milieu therapy. So what are the implications of all these in terms of our own psychiatric service delivery and education? The last three elements of cultural competence mentioned earlier are important here for us. And these are to be conscious of the dynamics inherent when cultures interact, to be conscious, to institutionalize cultural knowledge, and to develop adaptations to service delivery, reflecting an understanding of diversity both within and between cultures. We need to re-examine our own culture as Western-trained psychiatrists and how it impacts or interacts with our own patients' cultures. We need to look closely at our own attitudes towards traditional concepts, beliefs, and practices if we have to seriously tackle institutionalizing cultural knowledge, much more developing adaptations to service delivery. Efforts at integration, according to Dr. Amantillo, have gained momentum worldwide, and this has been acknowledged by the World Health Organization. But in the Philippines, our question is, where are we? Are we still at the level of cultural blindness, whence the scientific Western-trained doctor and the herbolario, as a distinguished psychiatrist, Dr. Vera Lapus, puts it, is not on speaking terms? If so, this is unfortunate. As Dr. Seneriche said, that whether we like it or not, our patients define an interface between psychiatry and indigenous healing practices, and they often utilize both disciplines for their behavioral problems. She suggested that collaboration with local healers, which I think Ita Alice has done and which we have attended again and again, may be necessary to cover the vast needs of our psychiatric patients as the clinical area overlapping present psychiatric processes and native healing processes is a big potent segment of the reaching out process by our patients and may be a healing reality for psychiatric disorders, particularly in a third world country like ours. In her own clinical practice as well as mine, Dr. Seneriche's worked hand in hand with some healers in the form of a professional partnership, referring to them when she felt that their help was needed, and we are happy with the outcome. In Iloilo, most of us psychiatrists are comfortable co-managing our patients with local healers, although we have not formalized any referral system. And I really wonder if this should be formalized. Our patients feel very comfortable going to us or continue coming to us when their local healers or the religious endorse our management. Part of our data gathering is to inquire about their help-seeking behavior so we will know who and what we are working with. We do caution our patients and their families about compliance with our medications, as well as the dangers of some traditional practices like putting hot harampol on the abdomen of patients, as we have seen second or third degree burns on some of them. We have also seen how Western concepts have made some inroads into our patients' consciousness, as some of them will say that although the local healers told them that their illness is a form of HISAP, but they doubt this, so they also come to us. Our informal survey of psychiatrists in the Visayas, done by Dr. Sharibel Inscandilor, one of my students, revealed that almost all respondents experienced hilot, which is a form of massage, and luya, which is a healing ritual with the use of ginger, as children. Some of us, that includes myself, bring our own children to the manukhilot for certain ailments. Most of us felt that traditional healers are part of our culture. Whether we like it or not, our patients would go to them even before they come to us. And so in conclusion, my dear friends, I have shared with you some of our experiences in the Visayas, mainly in Iloilo, which I hope are still in tune with our topic. Dr. Ignacio, another prominent Ilongga psychiatrist, challenged us to be deinstitutionalized and to be socially aware of relevant community conditions and to be open-minded and to be ready to modify or even change our traditional Western models of care when appropriate. So we now should no longer see ourselves in doing just clinical patient care in our clinics, because this should only be a small part of our overall task. In situations where there is only one psychiatrist for hundreds or thousands of the population and virtually no mental health infrastructure, it seems pointless to see only a handful of patients a day. Madamo ng salamat at maayong aga.